All right, everyone. I hope you can all hear me. My name is Tiffany Marrero, and I will be co-facilitating with Bree. And this is Advancing Sexual and Reproductive Health, Rights, and Justice. Just to do like some 5-minute logistic stuff. Everybody joining by computer or phone will just start on mute. So if you don't have anything you need to say, please mute your phones. Feel free to type them into the chat box on any questions you have. The chat box will be monitored to ensure that no one's questions get lost or anything. If you want to hold on to the end, we'll have time for questions and answers that you can ask to write them down in the chat box. If you raise your hand, then we can take you off of mute and then you can ask. So there's like a little raise hand button you can choose, and then we'll call on you, and then you can get off of mute, and then you can ask the questions. And welcome. We can just start with some slight intros of everybody. If you want to do that, you can start with Brianna, our first moderator.
Yeah. Hey, everybody. My name is Brianna Diaz, and my pronouns are she, her, hers, and I'm the new policy director for Positive Women's Network.
Welcome. And the one who was just talking just now, my name is Tiffany Marrero, and I'm just, like I said, I'm a visionary, I'm an educator. I really focus a lot on health and wellness and hospitality and HIV to kind of bring that outside perspective into the HIV work that we have. We'll start with our intro our panelists next.
Yeah.
Well, yay. Okay, so our first one is Amanda Posing from Human Rights Watch Women's Rights Division, Tammy Boyd, and I hope I'm saying this right, Björn Snyder. Did I say it right? I hope I said it right. And person kind of like they can intro themselves. So we can start with Amanda. Give a little.
That's great. Actually, I think Brianna has the bios.
Yeah.
Oh, I'm sorry. Can you hear me? I'm sorry. Did I go out of order? My bad. So sorry.
You're fine. I can take it over from here.
Can you also can you guys hear? Am I better? Can you hear me now? Is it better? Okay.
Yeah, you're perfect.
Awesome.
Great. So I'll introduce our panelists. Today we have Amanda Classing with us, and she is the acting co-director of the Women's Rights Division at Human Rights Watch. Her work focuses on sexual and domestic violence, reproductive rights, and women's health, indigenous and economic and social rights. She's a specialist in the rights to water and sanitation. Amanda has also researched and analyzed the women's rights impact of the 2016 U.S. election, including the restrictions on women's reproductive health and rights in the U.S. and abroad, threats to protections for survivors of gender-based violence, and efforts to decrease women's access to health care. Our next panelist is Tammy Boyd, who is the Director of Health Policy and Legislative Affairs, and is the main contact person for all policy and legislative matters. For the Black Women's Health Imperative. Sorry about that. Tammy is an established healthcare executive with proven expertise in government relations, political compliance, and advocacy. She has extensive experience in creating and executing federal legislative policy strategy and facilitating outreach to members of the U.S. House of Representatives and the U.S. Senate. And finally, our third panelist is Björn Snyder, and she is the Director of Public Policy at the Center for Health and Gender Equity in Washington, D.C., where she oversees the organization's policy priorities and strategies to promote sexual and reproductive health and rights within U.S. foreign assistance. In her work, she creates coherent and responsive advocacy strategies for a myriad of issues related to reproductive justice, human rights and law, HIV and AIDS prevention, education, advocacy, and foreign policy.
Can you guys hear me?
No,
right.
That's okay. You're muted.
Okay. Yay. All right. I hope you guys can hear me. And then just before I forget, I wanted to intro the mission statement of Positive Women's Network. which is to prepare and involve women and people of trans experience living with HIV and all of our allies that exist to strengthen and to treaty power with all women living with HIV in the United States. It was founded in 2008 by 28 diverse women, leaders living with HIV. PWN USA develops a leadership pipeline and policy agenda that applies to a gender lens to the domestic HIV epidemic, grounded in social justice and human rights, which is why it brings us to here.
Awesome. So I'm going to provide a little bit of background and context as to why we have a policy program here at PWN. So after the 2016 election, PWN went through an intensive process to update our policy priorities. We spent about 1 year taking leadership from women and people of trans experience living with HIV, and we're learning about the emerging issues that our constituency said most impacted their ability to live full, healthy lives with dignity and bodily autonomy. So since 2016, we've been fighting hard to maintain the policies that help protect our survival in the midst of grave challenges on the state and federal levels, some of which we will get into today. And we also know that we needed to do more than hold the line. We need to think forward beyond what's politically possible right now towards a proactive vision of the world we want to create.
Woo! Okay.
Yeah.
Now we're going to talk a little bit more about the new policy agenda.
Right, so the PWN USA's new policy agenda is composed of 6 key areas. We cover universal health care, economic justice, sexual and reproductive health, rights and justice, ending criminalization, trans rights, safety and justice, and ending violence against women living with HIV. For our full policy agenda, including previous webinars on these particular issues and fact sheets, you can check out our website at pwnusa.org.
Right. So I can just read out some of the webinar objectives. I hope you guys can hear me again. Number 1 is ground participants in understanding so it's the ground participants in understanding reproductive justice to learn more about the global Gag Rule and the impact it has on women and girls living with and around the world with HIV. Learn about the domestic Gag Rule and why it is a pressing human rights issue right now. And then number 4, organizing works, highlight policy solutions and actions that you can take. Super awesome.
Great, thanks. So some of you might be wondering, sexual and reproductive health, rights, and justice, what is PWN's vision? We have it right here for you. But PWN USA works towards a world where full reproductive justice and bodily autonomy, including the right to pleasurable sex, are upheld for any person of any gender and any HIV status. Bodily autonomy is the idea that individuals have the right to control what does and does not happen to their bodies. So we're going to get into a lot of issues today, and we're also at the very end going to provide you with ways that you can take action to address the issues discussed on this webinar. But, just to start off with, there's already things that you can do. So we can support repealing the federal ban on abortion funding by passing the Each Women Act, supporting, maintaining, and strengthening the Title X family planning program, which just recently had a kind of bad case outcome I'm sure our panelists will go over. We want to impose conscientious and religious refusal policies designed to legalize discrimination, and we wish to repeal laws that criminalize certain pregnancy outcomes. All of these things have a negative, impact on our reproductive justice, health, rights, and safety. So these are just a few ways you can get involved with protecting your rights. Great. So we also have a great fact sheet that's launching with this webinar that goes into a deeper dive into the issues that we're talking about today. So at any point, if there's anything here that piques your interest and you'd like to know how to get involved or have a deeper background and understanding of reproductive justice, please check out the fact sheet that is live on our website.
All right. So now we'll just get into it. So we'll hand over to Tammy Boyd from the Black Women's Health Imperative to help ground us in reproductive justice. So again, thank you, Tammy, and welcome. Woo-hoo.
Thank you. Hi, I'm Tammy Boyd. I'm with the Black Women's Health Imperative. So I'll tell you a little bit about who we are, what we do, and then I'll go to the brief background. and sort of the level set on reproductive justice. Next slide. So Black Women's Health Imperative is a national organization dedicated to improving the health and wellness of the nation's 21 million women and girls, physically, emotionally, and financially. We identify the most pressing health issues and invest in the best strategies, partners, and organizations to reduce mortality from chronic diseases, advocate for reproductive justice, and ensure women have access to health insurance and quality health care. The next slide. And this is just two of the publications, two of our main recent publications. We have a Black Women's National Health Policy Agenda, and then we also have an Index Us, which talks about the lived experiences of Black women, how we define health, and what some of our key health issues are. Next slide. And this is just quickly the contents page of the Black Women's Health Agenda, the National Health Agenda that we launched. And so for the health agenda, the issues range from ACA, Medicaid, Medicare, to reproductive health issues from Title 10, access to contraceptives, all the way to opioids and clean water. Okay. Next slide. And so a part of that agenda is a way for Black women to hold our policymakers accountable. We outline some of the key positions within the health agenda. And so it's sort of an empowerment way for Black women to talk to some of their key policymakers. Next slide. And then also, this is our Own Our Own Terms program. And it's an HIV/AIDS initiative that we have to support collaboration, solutions, and policies to HIV and reproductive health. And it's guided by Black women and Black women's lived experiences. Next slide. And so this is just the Reproductive Justice 101. The next slide, so the origin of reproductive justice. And so the term reproductive justice was coined by a group of Black women who were attending a pro-choice conference in '94, advocating for healthcare reform. And they saw the needs of women in communities of color were being ignored by the proposed policies. So while they believed that abortion was one critical resource for Black women, they were also focused on other essential needs, including jobs, education, housing, and the right to motherhood. And so reproductive justice takes a holistic approach, and the framework to abortion makes clear that such care is part of a person's entire life, and abortion is not sort of an isolated event. Next slide. In this slide is again sort of reiterating, what is reproductive justice. So the core reproductive justice belief is around 1, the right to have children; 2, the right to not have children; 3, the right to nurture the children we have in safe and healthy environment. And the next slide. And again, this is the 3 collaborative frameworks: reproductive health, reproductive rights, reproductive justice. And under reproductive health, that's more around the service delivery. It focuses on providers, medical professionals, community and public health educators. Reproductive rights gets into like the legal advocacy strategy on the legislative and the federal front. And then the reproductive justice piece is the movement building. Strategies and solutions are intersectional and comprehensive. It focuses on centering the leadership and power of those most impacted by reproductive professionals. And the next slide. And again, the reproductive strategies, justice strategies, support the leadership and power of the most excluded women and girls, build a network of allied social justice organizations, which we'll touch on a little later, and integrate grassroots issues and communities. Next slide. And this is just a slide of some of the reproductive justice threats. I mean, as you know, the different, for example, the abortion bans in Missouri, Georgia, the heartbeat bill, Alabama, and then also, someone probably will talk about it a little later, but also sort of like the Title 10, the Gag Rule, results that we just received. But those are just some of the reproductive justice threats that are out there now that surround us, the landscape. Okay, next slide. And this was the last slide. So we talked about the reproductive justice groups informing allied organizations. And so Black Women's Health Imperative is part of a group called In Our Own Voice. And a part of In Our Own Voice, there's several different reproductive justice groups. And Black Women's Health Imperative is a national group. We have several other groups such as Spark. They're in Atlanta, 2 groups in Atlanta. And we have there also in Pennsylvania, and they cover several states. But we work together in terms of the reproductive justice movement to move forward that agenda. And the next slide. Thank you.
Awesome, awesome, awesome. Thank you again, Tammy, for grounding us in this reproductive justice and giving us a sense of scope and depth on issues that are included. Now we're going to transition, I'm hoping to say the name right, to Revere Earn from Change. She's going to take over and tell us about a U.S. policy that's threatening the reproductive rights and health of people around the globe, especially women and girls living with HIV. You might be asking yourself why we're talking about U.S. foreign policy. Normally, PWN USA does focus on the U.S. Yes, there's a lot to talk about. But as you'll learn later in this webinar, in order to understand what's happening here, we first have to understand what's already happening around us. All right. Thank you, Bear, for coming for us. Let's learn what.
Thank you very much. Thanks, and thanks everyone for having me. This is an unfortunate opportunity to talk about U.S. foreign policy that we've been exporting around the globe during Republican administrations since 1984. And Amanda Classing will have a chance to talk about sort of what that may mean domestically. But we already have a sense of how these type of policies impact health and rights, and so there's a lot to learn. Next slide. So I'm going to talk about what is the global gag rule, how did it previously harm sexual and reproductive health and rights, including family planning, HIV prevention, abortion, and specifically women living with HIV, and then the expansion under the Trump administration, and which is expanded in several ways. Next slide. So what is the global gag rule? It's also called the Mexico City policy, the expanded Mexico City policy, and protecting life and global health assistance. But the global gag rule is what activists call it because it is at its core a speech restriction. Why are we talking about a speech restriction when we're talking about health and rights? It's because this type of funding speech restriction has a huge impact on who can get and give information, including where and how to get medical care that they want. So the global gag rule was first announced in 1984 by President Ronald Reagan, and it's been in effect during Republican administrations and taken out during Democratic administrations, but led to both bad health outcomes and instability in global health over the last 40 years almost. So the global gag rule says that foreign NGOs may not perform or actively promote abortion as a method of family planning while they receive global health assistance. So this applies to any foreign non-governmental organizations, any foreign faith-based organizations, and private entities, including for-profits. It excludes multilaterals like the UN, so it doesn't apply to UNAIDS or the Global Fund. It excludes national governments, so it doesn't apply directly to, say, the government of Malawi, even if they're receiving foreign assistance money. It doesn't apply to parastatals, which are sort of semi-governmental organizations like public universities abroad. And it doesn't apply to US-based organizations. the answer we've always given on why it doesn't apply to US-based organizations is because it would be found unconstitutional if it was applied to people with First Amendment rights, because it is a speech restriction and impacts what organizations can and cannot say. However, as Amanda will share, that question of would it be unconstitutional as applies to US organizations is less clear now than it was 35 years ago. Next slide. So this is a crazy phrase, abortion is a method of family planning. And it's important to remember that the global gag rule was first announced during the Reagan administration in the middle of the Cold War. Abortion as a method of family planning is a very specific, very American notion in reaction to the fear coming out of Western or Eastern Europe that people were using abortion as their only form of timing and spacing pregnancies. There is some truth to it in that in a lot of Eastern Europe, it was very hard to access contraceptives, but actually easy and states funded to be able to access abortion. But this is a big thing being reacted to by the sort of rising evangelical movement in the United States. And they define the Mexico City policy as forbidding non-US NGOs to do provide or promote abortion as a method of family planning. So the only exclusions, so the only places where abortion is permitted by these organizations is in the cases of rape, incest, and life endangerment. But it includes abortions for physical and mental health and abortions due to fetal anomalies. So that is sort of how the US has defined abortion as a method of family planning and built a whole program and a set of restrictions around it. Next slide. So what does it mean to promote abortion as a method of family planning? And this stuff's important because this is where we actually see a lot of this ending up being reflected now in US-based policies. But what it means is that you can't counsel, refer, provide or provide public information about abortion as a method of family planning. You also can't lobby for or against it. So what's so different about the global gag rule than, say, restrictions on individual sort of like funding restrictions that go with US money, and that happens both domestically and globally, is that this isn't just about what you can and cannot do. It is about what you can do with anyone's money, with your own money, with private donor money. It's not just what you can do with US money. So if the US is supporting ARVs for a clinic, it's not just about what you can do with that US money, it's about what the clinic can do writ large. If you are getting that money or those medicines from the US government, it then means that you cannot be counseling or referring women coming to your clinic on their legal abortion options. And so it's not just that it is, and this is where the speech comes in, it's not just that it's about what you can and cannot do within a program. It extends to entire organization and poisons everything they can do with anyone's money. So the way we've seen impact over the last 35 years, and to say how we anticipate seeing a lot of impact moving forward in the United States and around the world, is that either organizations cannot comply with this because they provide abortions, or they refer and counsel for abortions, or they're lobbying their own governments to change restrictive laws, that these organizations that cannot comply lose US funding and then have to close clinics. So we saw huge clinic closures for family planning and HIV in Ghana during the Bush administration. We've seen closed clinics and closed sites already in Mozambique during this Trump administration. And so whole individuals and communities lose access to health services. Another way we see impacts are where organizations can't comply, they lose that US funding, and then they have to end whatever, like sort of specific programs. And oftentimes those programs may be expensive ones. So programs for adolescents tend to take more specialized training, more specialized resources. Those are oftentimes the first to be closed down. Outreach programs are often the first to be closed down. Access to long-acting reversible contraceptives like IUDs that might take more training and specialized area might be the first to be closed down. And then the third way is that organizations that don't comply, that do comply, so continue to take US money, but have to stop doing something. So they may stop a teen pregnancy sort of access to care campaign because they were including information about safe abortion. They will stop providing counseling and referrals for women during clinical services. They may stop an advocacy campaign around maternal mortality or some other kind of health priority if they potentially involve abortion. Next slide. And then this is the next type of impact, and this is one of the ones that we are undermining on this very sort of this webinar, which is the fear and silencing. Groups become completely afraid to talk to each other and are very afraid of who is bound by the gag rule and who isn't. They're afraid to be in meetings together. Groups don't want to sort of be seen with groups that are known to provide or support abortion access. So it really has fragmented the women's reproductive health rights and justice movement during Republican administrations, where they break relationships, they break coalitions, movements get undermined. Next slide. So this is what we know happened during the Bush administration. And these are pretty dense slides. I'm not going to read them, but I wanted to make sure people had access to some of this data if you go back and look at the webinar later. Next slide. So what's important to note is that during the Bush administration, so 2001 to the end of 2008, what we had was this gag rule was attached to all international family planning assistance. And this is about $500 million a year that supplies contraceptives and supports programs and technical assistance all around the world. It also, sort of the rights framework with that also came out of the Cairo conference that Tammy referenced, and has had huge positive impact on women and girls around the world in the last 25 years since ICPD. So this, during the Bush administration, the policy only attached to international family planning funds, and what we saw were negative health outcomes and negative civil society outcomes. We lost a lot of access to contraceptive shipments. A lot of clinics closed down. The Ghanaian civil society still hasn't bounced back. And a lot of sort of shipments of contraceptives were cut off because a lot of the organizations that were most able to receive and do that programming were organizations that couldn't comply with the gag rule. Next slide. We also saw HIV prevention impact. There was a weird thing going on in the Clinton administration. It's too wonky to really want to get into, but basically we, the United States, through a precursor to the Bush administration, was providing essentially all of the condoms in Lesotho, which is a very small country in Southern Africa. And in the first year of the Bush administration, when the GGR, the Global Gag Rule, went into effect, all of those shipments were suspended. So the entire country of Lesotho lost public clinic access to condoms for an entire year, and actually probably longer in terms of actual impact, because the organization that could receive them and disperse them at clinical sites throughout the country was the International Planned Parenthood affiliate in Lesotho. And so the US cut them off from being able to receive funding, or in this case, condoms, and disperse them throughout the country. This is like so unsexy, right? You're talking about supply chains and availability of condoms, but it has huge health impact. And as everybody sort of has a sense, you get to depend on certain things in your clinical site. You want to see the same nurses if they're your favorite nurses. You want to pick up condoms every time you're there. And to have that kind of relationships and actual service availability upended has huge lasting impact on people's trust and engagement with the health system. Next slide. We've also seen enormous global abortion impact by the global gag rule. This is really data rich, and the reason it's data rich is because people like our Secretary of State say that this is an on its face lie. They do not understand enough about what it means to sort of engage with your own health to understand or care why women losing contraceptive access increases unwanted pregnancy and therefore increases abortion. And in the cases of where the global gag rule applies, almost all of that increase in abortion is unsafe abortion with maternal mortality and also maternal morbidity, so permanent disability as well as death attached to those sort of very unsafe abortion conditions. So the general thing to know is that the global gag rule increases abortion. The odds ratio of a woman in a highly impacted country was 2.5 times higher in sub-Saharan Africa during the global gag rule. In Latin America and the Caribbean, it's 3 times. And so just to know, and sort of, this is a huge takeaway. And it's also something that when you start looking at what the domestic rule it may have impact-wise, losing access to contraception, losing access to your primary healthcare providers, generally in these circumstances has increased abortion, and most of that abortion has been unsafe. Next slide. So I keep talking about this expansion. Like so many things with this administration, they took a really terrible idea and made it much, much worse. So the gag rule under the Trump administration has been expanded to all of global health assistance. So to 15 times the amount of money is now gagged as it goes out into global health. That includes all of PEPFAR, which is our global HIV program, which supports almost 14 million people on treatment around the world. It impacts all of our tuberculosis funding, our malaria funding, other public health threats. So a lot of what you hear about in the headlines about pandemic flus and responses to public health threats, that money is now gagged as well as maternal and child health, and then also the family planning and reproductive health. Next slide. So they've taken something terrible and made it much, much bigger. So we can't speculate about the extent of the impact, but we do have some early impact in the last 2 years. Amadefa is one of our colleagues in Mozambique, which is a very rural country with very poor infrastructure. Amadefa lost 60% of its budget and has had to close half of its youth-friendly clinics and laid off 30% of its staff. It's also just had to sever a lot of relationships, and that includes a lot of coalitions that they've spent years building and supporting. Similarly, we sort of have seen sort of enormous impacts in Zimbabwe, where about 50% of some local health facilities had to be sort of scaled back in terms of outreach. And outreach is, of course, what gets people into care in a lot of circumstances. Next slide. This is just a visual for folks to take away with them. This is a long report that I think PWN has linked for folks, but it is really the whole history of the data on what we know about the impacts in the last, from 1984 to 2018, and includes what you see is the sort of massive drop-off in one clinic for girls and young women on HIV services. So July through September of 2017 was the last time AMADEFA was able to receive US support, and October, so that's the fiscal year of the US government, ends on September 30th. So you can see the extraordinary cuts in their ability to serve clients between that first and then second quarter. Next slide. So for women living with HIV, and I work with my colleagues at the international community of women living with HIV, particularly East Africa, has been very, very active on this. And ICWEA actually is an organization that had to end their relationship with the US government because of this policy. There are a lot of HIV groups that have been impacted for the very first time because of this massive expansion. So women living with HIV-led and serving organizations have lost funding in dozens of countries because they're put in the position where either they can tell the women they work with and the women they are and the women that they sort of lead about all of their available health options, about counseling and referrals. Either they can engage in their sort of their own SRHR, sexual and reproductive health and rights priorities, or they can take US money. And most of them have had to choose to go with their organizational missions and their sort of moral core and lose funding and have to cut services, projects, important things, especially around PrEP access. And then we've also seen organizations who do continue to take funding, but have had to lose some of the things that they provided that were potentially very, very important for their clients at either a clinical or sort of a more community service level. We have some huge gaps in data that unfortunately in a couple of years I'll be able to tell sort of in more concrete numbers, but women living with HIV oftentimes access contraceptives and contraceptive counseling through US funded programs. And where they're losing those access, we just don't know necessarily. One of the places that the global programs are very concerned about, and I don't think we're well prepared to actually capture a lot of this harm, is that in a lot of global health settings with sort of mixed domestic and global donor clinical priorities and sort of how things have been funded over time, women oftentimes test positive. And this is very similar to the US in many cases. They test positive for HIV at their first antenatal care visit. So when they find out they're pregnant, they're oftentimes finding out they're HIV positive at the same time. They then get referred to what are called PMTCT clinics, prevention of mother to child transmission clinics. Most of those PMTCT settings are funded by PEPFAR, so by the US government, and therefore gagged. But what we're worried about is that those places where they're actually testing positive, a lot of those are family planning clinics who are going to lose funding. So we're not sure how many women are going to lose the opportunity to test at the beginning of their pregnancies and then not get connected to care, because that's where a lot of the clinical closures are happening. And then finally, this is a sort of an extraordinary and very, very tough issue to talk about. But as we roll out dolutegravir, both in the United States and around the world, there's a lot of amazing things about DTG. Side effects wise, adherence wise, many, many women prefer it because of the side effects and many of the really positive benefits. As I assume sort of most people have a sense of, there's been a safety signal on it with concern about women being on DTG at the time in which they become pregnant. And concerns not for their own health, but for fetal development and the possibility of neural tube defects in fetal development. This is really important because the global gag rule explicitly prohibits counseling and referrals on pregnancy options, including safe abortion care in the cases of fetal abnormality. So if you are a woman living with HIV who wants to go on dolutegravir, how do you give informed consent if your provider cannot tell you what your options are if you are to become pregnant while you're on dolutegravir? When we say this is a gag, this is what we mean. Your doctor cannot tell you the truth about dolutegravir, about why it may be the right choice for you and what some of that risk is. If you go, if they work for an organization that's been gagged. As countries around the world are coming up with their clinical guidelines about dolutegravir, this is an issue we run into again and again. Because even if the clinical guidelines organizations get US money, they're struggling about whether they themselves, in their clinical guidelines, can tell the truth because the US government is telling them they can't. So DTG is an ongoing issue and really, really impacts how women living with HIV are receiving information and whether they're actually able to give proper informed consent when they're making the decision about whether to switch to a new ARV regimen, particularly if they're of reproductive age. Next slide. I'm gonna leave it there. I would just, before I hand it to Amanda, so I used to work in Indiana. Mike Pence was my representative for a long time, and I worked on HIV in Indiana. And I think there are a lot of folks in PWN who understand what Mike Pence did as the governor of Indiana to the HIV response there. And by targeting Planned Parenthoods in the southern part of the state, what we saw was the largest domestic epidemic in 20 years. Because those clinical sites in southern Indiana were some of the very few places that you could access condoms, counseling, pregnancy tests, and HIV testing. And I worked with those clinics that had to close. And so, and of course, Mike Pence's governor had to declare a state of emergency, bring in needle exchange programs, and really make the federal government respond to the problem that he created. The reason this is so important is that Mike Pence is the architect of the expansion of the global gag rule to PEPFAR and our entire global AIDS program. He knows what it does to the AIDS response and to the lives of people living with HIV when you do these kind of attacks on women's healthcare providers, and he chose to do it anyway. So with that very, very bleak view, I will say thank you.
Awesome. Thanks, Bjorn. Yeah, that is, as you say, it's horrifying, it's alarming, and it's upsetting, but we greatly appreciate you sharing your knowledge on this and your expertise so we know how to react in this very sad time. So thank you for getting into the human impact of the global gag rule. It's a human rights issue, you know, so we've been saying this whole time, and Amanda, our next presenter, knows it all too well. Amanda's from the Human Rights Watch, and she's going to explain some human rights issues cropping up in the US around abortion access, and this is called the domestic gag rule, which, as you probably have guessed, it's related to the global gag rule and all this resurgence of religious refusals we're seeing. So with that, I'm going to turn it over to you, Amanda.
Great, thanks so much. And I actually am going to start, Kelly had asked me to give a little framing around what is a human rights framework? Why is it important to think about these issues from a human rights perspective? Because it actually will allow advocacy or new avenues or new ways of framing advocacy. So I'm going to start with a bit, what do we mean by human rights? So sometimes in the United States, we use it as a rhetorical tool. We'll say something is a human rights violation or it's a human rights issue, and people and organizations want to underscore the weight or gravity of an injustice by using rights language. But actually, human rights are part of a legal framework that have the force of international law. And coming with that is obligations by the government to protect, promote, or fulfill human rights. And these rights encompass binding international human rights documents and other consensus documents that both Tammy and Barron already alluded to, one of them being the Cairo outcome document. Next slide. So what does international law have to say about reproductive rights? There is authoritative interpretations about that say that when a government denies women and girls access to reproductive health care, it's a type of discrimination, and that it jeopardizes a range of human rights issues, including their right to health, to non-discrimination and equality, privacy, information, and the right to decide on the number and spacing of children. Now, these are internationally recognized rights, rights that in some cases the US government doesn't recognize within its own jurisdiction. And yet, within an international framework, they exist and there are obligations related to that. Next slide. So one international treaty, and when something is a treaty and a government is actually a signatory and a ratifier of that treaty, then there are binding obligations that come along with that. There are also treaty bodies that are able to assess and monitor whether or not a government has actually been implementing its or fulfilling its obligations under international law. It's not the same as a court, and it doesn't have the force of law in the United States as a court, but it is an alternative and an important entry point for advocacy and for establishing that a human rights issue or violation has taken place. And so the US has ratified something called the International Covenant on Civil and Political Rights. And its treaty body, the implementing body that monitors whether or not governments are fulfilling their obligations, is called the Human Rights Treaty. And it has instructed states that when they report periodically to the committee on how they're doing related to their human rights obligations, that they need to actually provide information on measures that to ensure that women do not have to undergo life-threatening and clandestine abortions. So they really see that there is a human rights component to accessing safe abortion care. Next slide. There's also another convention or treaty that the United States is a party to called the Convention Against Torture. Oftentimes people think about torture as a form of physical violence that police perpetrate against people in their custody, for example, or that happens in the context of war. But torture, the interpretation of what torture and human treatment can look like has been interpreted by the UN Committee Against Torture. And it has actually looked at places where there are extreme abortion laws and extreme restrictions to abortion or other types of policies that require women to continue pregnancies against their will. And what that committee has actually said is that forcing women to experience severe pain or suffering to continue a pregnancy by criminalizing abortion with few exceptions is incompatible with the right to be free from torture and other cruel, inhuman, or degrading treatment or punishment. So it really elevates the importance and the rhetoric around what it is to access reproductive health care. Next slide. So what does this mean and what in the context of the United States? Well, some of the things that we are seeing, I'm going to start with the religious refusals and conscientious objections clauses because it's a nice bridge to what's happening internationally, and then we'll definitely go into the Title 10 domestic gag rule. So in addition to the global gag rule, something that we're seeing that has cropped up before in U.S. assistance and is a part of some of the different assistance programs, but also that we're seeing crop up in countries around the world, is the use of conscientious objections and religious refusals to actually prevent people from accessing care that they need or have a right to. So what this looks like in practice is that there might be something legal on the books to access, say abortion or non-discriminatory LGBT affirming care, and yet there are conscientious objection laws that allow doctors to refuse patients care. And in some countries, Chile is an example, that conscientious objection has actually been increased to include institutions. So entire institutions can say that we just don't provide this care. And the government is actually affirms that they have the right to do so, despite the fact that that type of care is legal. It turns out that, in fact, within the United States, private institutions have actually do the same thing. They are able to determine what it is, what type of care they will and will not provide based on their religious or moral objections. And increasingly that we're seeing that this has been done in cases where institutions are taking government funding. So there were about 25 different pieces of laws around conscientious objections or moral objections that did not have a coherent implementation or regulatory regime. So the Trump administration decided to put this all together in a very robust and harmful law, what is a final rule on protecting statutory conscious rights in healthcare. So basically, it's this massive religious and moral refusal law. And what it does is it takes the rhetoric of rights, civil rights or human rights, and pits it in the rights of a person to their conscience or their moral or religious beliefs, and pits it against people's right to access healthcare and their right to sexual and reproductive health and rights. And it seems to think that there's a zero-sum game. In order for people to access care that violates somebody's moral center, then we should actually block people from having to provide that care, rather than there being a robust analysis of how rights should be affirmed in any particular case. So this rule is, luckily, it has not gone fully into implementation and is currently in litigation. But let me go ahead and lay out what it does and what our big concerns are about it from a human rights perspective. So it allows, as I said, people to use a religious or moral objection to say that they won't provide a certain type of care. So that could be anything from contraceptive care to providing care. We've seen in our own research pediatricians refusing to provide care to a child whose parents are same-sex couples, or people refusing to provide transgender-friendly care, people refusing to provide certain types of contraceptive care. And so it allows there to be a moral or religious refusal, and then it creates a body within HHS, Health and Human Services, where people can file complaints if they feel like they've been discriminated against when they actually do assert their moral or religious conscientious objection. But our concern is that in writing this rule, which there is a human right to conscience, the government failed to appreciate the significant barrier that women, LGBT people, and others already face when attempting to access healthcare that meets their needs. And it also failed to look at the likelihood that that rule would not only fail to eliminate that barrier, but would actually exacerbate those barriers and prevent people altogether from accessing care. The rule also codifies vague and open-ended definitions that would, in our analysis, permit unfettered discrimination in healthcare settings. The idea of going from a religious belief to a moral belief and not having to articulate it in a way that conforms with the human rights framing around religious freedoms is an opportunity for discrimination to breed in a really, really unseemly way, and often outside the sites of government without there being any sort of access to remedy. So people will be turned away from care, and rather than being able to seek care elsewhere, they will be discouraged from seeking it at all. And our concern from a human rights perspective is it actually breaks the long tradition of religious and moral exemptions under domestic and international law, which was is calibrated to look at all the rights holders in a situation and carefully balance the rights of one person against the rights of another person and ensure that everybody's rights are protected in a way that is best way forward. And instead, it provides this blanket protection for religious exercise without any mechanism to ensure that the rights and health of others are not also jeopardized as well. As I said, this rule there have been cases filed against it, and it's currently, the lawsuits are pending. So there is a case filed by the state of California. It was filed early May, and then a few weeks later, 23 states and municipalities actually filed a case against it. So we'll see what will actually happen there. Okay, next slide. So human rights principles and why they are so important when you're analyzing whether or not a rule or a pending piece of legislation or regulation is rights respecting, but also whether the solutions are rights respecting. You look at whether or not equality and non-discrimination are respected, whether there's been participation of affected individuals, if there's accountability and transparency in both the drafting and the implementation, and whether people have access to information. And in every case, when you look at how this rule is written, none of these principles were respected. Okay, next slide. And I'm realizing now that the conscientious objection slide was out of order. I was like, why did it come up there? Okay, so why human rights framing? Human rights framing brings a robustness to advocacy that actually allows you to operate outside of a court system. We're so used to leaning on litigators to actually do the important and hard work of blocking rules, but a human rights framing also allows activists and advocates and directly affected individuals to define the relationship between the government and the authorities that implement laws as duty bearers, those who have obligations to respect, protect, and fulfill human rights, and citizens and people living within its borders who are recognized as rights holders. It's a definition of power, and one that actually assigns significant amount of power to rights holders and allows for strong advocacy against duty bearers to actually hold them accountable for their obligations. It also requires both ensuring that access to resources and addressing the particular attention to the needs of vulnerable and marginalized groups is a forefront to any policy. And when you actually look at the conscientious objection law rule, and if you look at the global gag, and in a second when we talk about the domestic gag, it actually does the opposite. They all, instead of ensuring that access to the most marginalized populations are prioritized and actually implemented in policy, they absolutely blow that up and actually take steps to limit access to and create additional barriers to care for the most marginalized populations in any one place. The other thing about human rights framing is that it's not just about identifying the problem, but it's also identifying that the solution requires meaningful participation of affected populations in the solution making around any one issue. It is in many ways a substantive equality or equity lens for addressing problems or issues that arise from systematic abuses. And also human rights framing isn't just about, the issue ahead of any one government official. It's similarly to how Tammy framed reproductive justice lens looks at the whole life of a person, looking at economic issues, looking at environmental issues. You have to look at the systemic problems that constitute barriers to the enjoyment of human rights. It's a holistic approach to the lived experience of individuals and how they are able to access or fulfill their human rights. So human rights framing is an opportunity to have that holistic look. Next slide. Okay, and so the Title 10 domestic gag rule is the opposite of a rights respecting rule, and very similar to what Baron laid out. This is a rule that actually is targeting doctors and what it is they can and cannot say in a relationship with their patient. So what it looks at is the Title 10 funding. So Title 10 funding is the federal family planning dollars. It is the money that goes to clinics, more than 4,000 of them around the country, that provide care to uninsured and low-income individuals, family planning care. Oftentimes these clinics, about 40% of patients with Title 10 funding are actually provided services through Planned Parenthood, but the clinics can be community clinics, they can be county-run clinics. These are oftentimes the source. The Title 10 funding is the source that actually allows them to operate and provide a full suite of services, because it's a guaranteed amount of money to bring patients in, and then there are other ways to provide them services. So it's not just, when you start to think about how this impacts clinics, it's not just about access to family planning care, it's about access to holistic health care, but that the Title X funding is the anchor funding that actually allows these clinics that operate in marginalized communities, rural communities in particular, to continue to function. So this rule was adopted, the binding rule was actually adopted in February of 2019, and then it would stop health providers in clinics from using, so if you have a clinic that is receiving Title X funding, health providers could not provide patients with full and accurate reproductive health information or about or services about all of their pregnancy options, including access to abortion. So this is a intrusion into the patient and doctor relationship that wouldn't exist if you are a person that is able to pay for your funding or pay for your healthcare directly, or if you have insurance. This is a specific type of intrusion that's happening in the patient relationship that is happening only in these populations that are receiving care because they are uninsured or low income. So essentially, if you're a provider that receives Title X funding, you have to make a difficult choice, similar to how Barron laid out the difficult choices that providers have to make abroad. You have to decide, do you want to provide the subsidized family planning care, which the subsidies are often what allow you to provide services to the broadest number of people, but also can you continue functioning just to keep your doors open? So do you want to continue to provide that care, the care that's needed by most marginalized people in communities, or do you want to provide abortions or access to information about abortions? But you can't do both. That is what the rule essentially is telling you. And it also, as I say, it prohibits providers from making abortion referrals. So if you make that difficult decision that in fact we don't provide abortions, or we don't provide that many abortions, and our community is best served if we continue to provide family planning care, you also cannot refer people out to places that would be able to provide them with care. So I want to talk a little bit about who this hurts the most, because going back to the human rights framing, we know that states have an obligation to direct resources to the most marginalized populations. And in fact, what this rule does is it targets a patient population where Black and African American patients make up 21% of Title X patients, and Hispanic and Latino patients make up 32%. So we're talking about a population of patients that are predominantly women, Black women and women of color, or people of color that need access to family planning, and many of them living in rural or underserved communities. Next slide. See, this is, for some reason, the religious refusal slide was in there twice. I was about to say it threw me off, but I think we're back on track. So let me tell you where we are right now with the domestic gag rule. I was prepared to tell you that it was currently blocked by the courts and that we'll see what happens there. But in fact, as of today or late last night, the Ninth Circuit actually ruled that the injunctions that by the lower courts to the implementation of the rule have been lifted. So I don't have a lot more details because this is such a recent case that has come down. I can't tell you the specifics of what the next procedural steps will be within this, but it is going to escalate the issue. Presumably there will be other circuit courts that will come out with rulings, or this will be there will be some petition to the Supreme Court. So we will, as Barron said, find out whether or not this is actually a constitutional infringement on freedom of speech into that, or privacy issues. We'll see what it'll turn on. But I did also want to flag that while this is happening in the courts, there's a lot of advocacy that's happening at the legislative level, and there's appropriations to the funding bill that Congress has to pass every year that funds all the different government functions, including funding Title X. That went through the House this week, and in fact, the House adopted a provision within the funding measures that would actually repeal the domestic gag rule now, or it would block it, similar to what it has done now with the global gag rule as well. Now, what the next steps of that would be is that the Senate would have to do the same, and we all know that the Senate is not the same as now the Democrat led House. And so the possibility that that will be maintained in a final funding bill is quite low. But I think what's important to note here is that there is a lot of advocacy that's happening, that is effectively happening around trying to block the implementation of the domestic gag rule. So I'll pause here and leave it to you, Kelly.
Awesome. Thank you so much for that. Real quick, Amanda, we actually, you're perfect. We actually have a question, if you don't mind clarifying. Can you explain real quick what an injunction is and what does it mean that it's now been lifted?
Sure, awesome. So when something happens that the government does something that you believe is a violation of constitutional rights or some other rights, and there is a real fear that if that action moves forward, there will be irreparable harm. And we all know that courts take a really, really long time. So you can run to the court and you can file your lawsuit, but you can also file a request that the judge says, you know what, nothing happens until I have the time to actually sit and make a ruling. And so in a number of trial courts, there was the assessment that in fact the risk of harm was so great that in fact the implementation of the rule had to be stopped until courts could take their time to consider whether or not there was a constitutional issue here. So basically the clock stopped on the rule going into effect. And if in fact the Ninth Circuit has reversed that, then the courts holding back the implementation of the law is now at risk. Again, I'm not entirely sure what other pending, if there are other pending cases in other circuit courts, so in other appeals courts, or if this will go up on what is called cert, which is basically going to the Supreme Court and saying, come on, you got to resolve this. Like, we don't like how this appeals court resolved it, or there's disagreement among your courts, so you have to rule on this. So we're now in this position where we have to see what happens next. But essentially that holding back of the implementation of the law that the court provided has now been lifted. Does that clarify?
Yeah, for sure. Thank you so much. So just to reiterate, an injunction is just someone asks for this law or policy that's supposed to be implemented. The injunction says, no, we're going to stay it. So it's not being able to be implemented. But as of about an hour ago, the Ninth Circuit lifted the injunction against the domestic gag rule. So allegedly it's supposed to be going into impact, as soon as possible.
Yeah. And as somebody said, one of the questioners asked, it was a nationwide injunction. So and this is a failure of my knowledge, so apologies to everyone. I don't know if there's another injunction under a different circuit that is currently still in place. So I need to actually read into what else is pending. Yes, the injunction would not, if the Ninth Circuit lifted the injunction, it would have lifted it nationally. So whether or not another one is still in place and holding is a question for the litigators.
Awesome, thank you.
Brianna, do you want me to chime in? So I'm going to say just a couple words specifically about Title X as an HIV service sort of provision center in the United States. AMFAR, the Foundation for AIDS Research, actually has a really terrific resource on this. Ahead of the rules change, they did an assessment of how much Title X clinics contribute to the HIV response, basically, in the United States. And obviously, one of the ways they do that is by providing contraceptive access and counseling to women and girls living with HIV and helping them find family planning options, if there are family planning options that they want that work for them. But one of the other ways Title X clinics support the HIV response is by being major contributors to HIV testing, prevention services, and linkages to treatment care. So the AMFAR data is really pretty troubling in terms of the type of impact we could be seeing. We talk a lot about Planned Parenthood, and they're not the only Title X providers who will be impacted by this, but they are certainly the clearest cut network of centers that will be impacted. And there are quite a few states in which Planned Parenthood provides between 15 and 25% of the HIV testing in the whole state. So states like Indiana and Ohio, Iowa, Minnesota, Wisconsin, Colorado, Utah, Planned Parenthood is providing but anywhere between like 12 and 25% of the HIV testing happening in that state. So when you're talking about what it means to take federal funding away from those sites, you're talking about a huge reduction in available HIV testing, prevention, and linkages to care and treatment, which is a really, really big deal in a set of services that are already being attacked in a lot of other ways, and maybe make it really, really hard for people to get prevention services, to get testing, and to get linked to care. In addition to really undermining the ability of all women and girls and men and boys to a somewhat lesser extent. Title X actually provides a lot of services to men and boys, but to really be able to access family planning and contraceptive services, including people living with HIV. So I really do recommend AMFAR's brief. It can really help support advocacy around how attacking Title X really attacks the HIV response in the United States, much like we see globally. And very similarly, they talk about this as an abortion restriction. And what we know is that healthcare doesn't work that way. It attacks the whole myriad of the way people want to communicate with their nurses, their doctors. It means people are getting not the information they want and not at the site they want. And that the impacts are, expand far, far outside just access to contraceptives, which would also be terrible if that was where they were limited. But the impacts extend well beyond that.
Great. Thank you for that clarification, Bjorn. Okay, so with all of that news, which seems really disheartening, there are things that you can do. There really are. There's a lot of things we can do. So one thing that we can do is that we want to repeal the global gag rule by passing the Global HER Act. And so the Global Health, Empowering, and Rights, or HER Act, would end and prohibit future iterations of the global gag rule. As Bjorn mentioned, the global gag rule came about under the Reagan administration, Bush. It went away during the Obama administration, and it came back under Trump. This bill would get rid of it forever. It would also allow foreign non-governmental organizations receiving U.S. funds to use their non-U.S. funds to pay for any legal medical service, including abortion, and would allow abortion-related advocacy. So to put it simply, it would help protect healthcare for millions of people around the globe. So there's an excellent fact sheet on the Global HER Act and our resources, which I will share in the chat box once we get there. I will share all this. And you can always turn to Change, that, Bjorn's the director of policy, therefore. She is one of the best advocates on this, so you can always contact her with more questions. For number 2, we support ending the domestic gag rule. As we've talked about, or that Amanda mentioned, the House of Representatives is trying to use the appropriations process to block the domestic gag rule. So the Labor and Health and Human Services appropriation bill just passed the House, and it contains provisions saying that the only way there will be any federal funding for Title IX, period, is if the domestic gag rule is not included. So right now, this has passed the House, and it's sitting in the Senate. So I recommend, if you can, call your senator and tell them to immediately end the domestic gag rule. And we are happy to provide that information on how to contact your senator. So the bill is short of a total fix. However, it is not perfect, is that it still contains a Hyde Amendment, an appropriations rider that prohibits federal funding of abortion care. And as we know, even passing, the appropriations bill in the Senate is an uphill battle, but it's a positive step in the right direction. And finally, share information. This administration is trying to make it harder and harder for people to know their rights and access to safe and legal abortion care. And you can push back. So learn about who provides abortion care in your area and how you can help folks find affordable abortions. You can learn more about crisis pregnancy centers and warn people to stay away from them. So tell your family, friends, and community about the Gag Rule, both domestic and global, and emphasize that we are fighting in the courts, we're fighting in the legislature, state and federal, and we're fighting in the ballot box to defend reproductive rights, health, and justice, because there is this election coming up in 2020. Click. Okay, so now we're going to open it up to questions. So I'm sure you all have a lot. I've seen it pop up in the chat. So if you can, just use the raise your hand or type your question in the chat box, and I will happily read it to our panelists who will answer your questions. So start asking.
But really quick, can we give a shout out? Come on, Bree, I feel so ready after that. Like, honestly, that was amazing. I'm ready, you guys. That passion was great. I'm done.
Awesome. Okay, cool. So I do have one question Nana asked, of course, and it says, you know, what I've seen in parts of the domestic gag rule will go into effect immediately, but not being able to provide abortion referrals, but other requirements like the physical separation of abortion from non-abortion will go into effect in March 2020. So her question is, are there any more specifics of the Ninth Circuit ruling and its implication that can be shared at this time? If not, or if so, is there any advice to advocates on next steps on addressing the Ninth Circuit's ruling in particular? Panelists, do you have any advice?
So it's also new. So I mean, this is the same information that I've seen as well as the analysis of the Ninth Circuit. But I think the question is when and if the Supreme Court will take cert, which again is the question, like, dear Supreme Court, please take this case and resolve it. And I don't know what the strategy would be about where this court necessarily would be. So there will be, there have been over the last, 6 hours, more and more statements being released, and I think there will be calls to action. So my commitment is that as we know more information, we'll certainly share it with the organizers of this this webinar, so it can be shared more broadly, but also be looking to some of the Title X providers to be highlighting what the next calls to action will be in order to raise the profile of this issue.
And, I'm the director of public policy for an organization, so I would be bereft if I didn't say this. But one of the things about these issues is, especially if you live in a conservative district, your member doesn't actually hear about them very often. The global gag rule, the members of Congress that support it are not ever faced with the consequences, and the women and girls and men who are harmed by the policy being done in the US sort of citizen's name are never able to vote and rarely heard. And so if you call your member of Congress and say, I am so opposed to the global gag rule and here's why, and say it hurts women living with HIV and it increases abortion, and you need to know the consequences of this thing you support, you may be the only person they ever hear from about this. And you can have a real impact in changing the enthusiasm of your member of Congress. They're not faced with the consequences, and so they really do need to hear from you. And that's true on the domestic rule too, especially if you have a conservative member of Congress. They really do need to hear that there is not universal support for this. You and the sort of the story you can tell about why you need access to good healthcare and why other people deserve the same thing is a really important voice for your representatives to hear. And I think there's a tendency to sort of say, well, my member's good, and so I don't need to call them, but call them and thank them, because they don't get that very often. Or my member's terrible, they're a nightmare, they do everything wrong, they're not going to change their mind. And that's true in the short term, but you do have a chance to sort of dampen their enthusiasm for a policy, give them information they haven't heard before, make them feel bad, which is its own reward, or just make them understand that there is a human impact. And this is, even if you don't sort of see a short-term reward, even if you talk to a young member of their staff, that person might stay on the Hill. They might be somebody's chief of staff in 5 years. And if you have gotten to them first, to start making them really think harder about how we talk about abortion restrictions, but they actually increase abortion, make it less safe, and harm people who need healthcare the most. You have a chance to really impact how they think about this issue in the long term.
Great, thanks. All right, we have another question. This one's specifically for Tammy. The question is, if the global gag rule impacts trust and engagement of patients with the healthcare system in which they reside, is this a particular concern to the Black Women's Health Institution, considering the domestic gag rule, given the historical and current abuses against Black women in the healthcare field in the US? Are there any, do you have any looming concerns about what impact the domestic gag rule will have on HIV prevention and treatment, specifically with Black women and people of trans experience? You're on mute.
Okay, can you hear me or?
Yeah, that's perfect.
Oh, okay. As you know, Black women are disproportionately impacted. I mean, the gag rule would disproportionately impact Black women. I mean, in terms of what we're concerned about is access, and even the preventive services. A lot of the services that Black women receive, they receive them through Title 10. So we are very concerned about that, and we'll definitely be, and we have been, and we'll definitely be out front in terms of trying to overturn this rule.
Awesome. Thank you so much. Yeah, so I just want to end our discussion today with, if you all don't mind, panelists, giving us one key takeaway from today, like the final piece of advice to members on the ground, residing in southern states and so forth. What is the biggest takeaway that you can give them? Advice for next steps.
Are you asking each of us, or are you asking me that?
Each of you, one at a time, please.
Okay.
You start, Tammy.
Okay. I'm sorry, could you repeat the question?
Yeah, you're super good. So what's like one takeaway you could give our participants today about what they should do next steps on this particular issue of abortion bans, domestic gag rule, and global gag rule?
Right. And I think someone mentioned that in terms of what was in the labor HHS appropriations on the House side, I mean, one main thing is definitely to call your senator and your elected officials and just weigh in on that decision and definitely get out front in any way you can. I mean, holding meetings so your legislators, your policymakers are aware, that we don't support this issue. We don't support restricting access.
Great. Amanda?
Yeah. One thing that I would say that leading into an election year next year, really use the opportunity of town halls with candidates, or if your organization is preparing questions for candidates, that you get people on the record saying that they will repeal these harmful policies. You'll see the Amnesty International just sent out candidate questionnaires to presidential candidates, and actually questions about the global gag are a part of that questionnaire. But I think it's really an opportunity when we talk about holding representatives accountable, holding government officials accountable, getting them on the record on what they say they will do, and then being able to really push them and raise the political cost of them failing to do so. The global gag rule exists because there was not the political desire to expend capital when Democrats were in power to actually force through a codified repeal. So now we are able to still go with the winds of power, changes at elections. And so I would really encourage people to increase the political cost of ignoring the reproductive health needs of marginalized populations.
In addition to what I said before, I would just say that the majority of voters, the majority of Americans are with us. The majority of Americans, the vast majority of Americans support abortion access, and the majority of Americans don't support the global gag rule. And when you've got this kind of disconnect between how people actually feel and voters, as Amanda said, we have to increase the political cost of our representatives for not representing us correctly on this. And they need to know what it's costing women living with HIV. They need to know what it's costing health systems and how people trust their providers. And so they need to hear from us and hear that we expect better of them and we expect better policy than this sort of crappy anti-abortion rhetoric couched as healthcare that they're providing right now.
Great, thanks y'all. So we do have plenty of resources, some of which we went over today, our panelists touched on, and obviously you cannot click these hyperlinks, but we will be sending these resources out over the email chain. So yeah, we actually have, our panelists were mentioning that you can call your senators or call and demand that they pass the domestic gag rule, appropriations, inclusive bill. Planned Parenthood has provided a script for that. We will include that, so we encourage you to do it. That's pretty much it. Click, Kelly. Cool. So just a final reminder, we have one more webinar in our policy series that will be happening August 8th. And it is on advancing trans rights, safety, and justice. So please stay up to date, sign up and attend that one. It's going to be amazing, just like this webinar has been amazing. So thank you again for attending. Thank you so much to our panelists, Bjorn, Amanda, Tammy. Thank you for your time, your expertise, and dedication to this issue, even though things seem kind of gloomy right now. We really appreciate all you're doing for the community.
Thank you, Brianna. Thank you, Tammy. Thank you, Bjorn. Thank you, Tiffany, Kelly.
Woo! Thank you, Bree, of course.
Thank you,
The
everybody.
most amazing facilitator ever. I feel fired up. I'm going to call my person right now. I'm ready.
Thanks, everybody.